Southeastern, sir.
Yeah.
Southeastern Hospital.
Okay. And our faculty today will be Professor Shamita Chatterjee, who is Professor of Surgery at IPGM and SSKM Hospital. So, Saptarshi, it is a exam scenario. You got a card of modified radical mastectomy. So, before usually start the operating discussion, we have some discussion on indications and maybe some other options alternative to MRM. We can discuss. Professor Chatterjee.
Good morning, ma'am.
Good morning, sir. Good morning, Saptarshi. Are you ready?
Yes, ma'am.
Okay, great. Can you just hike up your volume, please? That it's better audible?
Yes.
Okay, thank you.
Yes,
So,
yes,
as
ma'am.
sir said,
Yes.
you picked up a card which says that it is a MRM. Okay.
Yes,
So,
ma'am.
what first and foremost, what will be the indications for MRM in this case? Do you want me to give you a case scenario? Okay, I'll give you a case scenario. So, let's assume that it is a lady with a 2 by 3 centimeter mass in the upper outer quadrant of the right breast. 2 by 3 centimeter upper outer quadrant of the right breast. It is a T3N1M0 lesion. T3N1M0 lesion. What is your approach going to be?
So, ma'am, this is a case of a T3, ma'am, 2 into 3 centimeter, T2.
3 into 3 centimeter.
T3N1.
T3. I changed the centimeter. I made it T3.
Yeah,
T3N1M0.
So, ma'am, this is a case of a locally advanced breast CA. So, we have to first give the patient the neoadjuvant chemotherapy, and then we can plan for any surgery, depending on the response of chemo, whether to go for breast conservation or MRM.
Okay. So, the first point will be discussion with the patient as to what she wants. Right?
Yes,
if she wants breast conservation, definitely being a locally advanced, you are going to opt for NACT. But if the patient wants an MRM, is it mandatory to give an NACT prior to commencing with MRM?
In this case, as it is operable, so we can go for upfront surgery.
So I know it's an operative card. I'll just touch upon one issue briefly, that even if it is an operable mass, what is the advantage or disadvantage of giving NACT?
First, ma'am, if it is a triple negative case, then there is a chance of in vivo sensitization of the chemotherapy. That's important. And the NACT can shrinkage the tumor, so we can downstage the tumor.
Okay, downsize the tumor.
Downsize the tumor.
Yes. What else? Why else can we give MRI? Even though patient says very clearly that I want an MRM, why else can we give her NACT?
And we can determine the prognosis of the patient depending on the response to chemotherapy.
Okay. So NACT, other than the commonest indication being that it is going to downsize the tumor, make it more operable in case of advanced disease. As you said, it could be in a triple negative. This is the way forward. Also remember that this is a very good way of knowing the response of the tumor to the particular drug. If you do an MRM upfront and then give the adjuvant chemotherapy, you may not be able to assess how well she is responding to it. So when you give an NACT, you have a pre-operative assessment as to how well she is responding to that particular drug. And if she is not responding following her surgery, you may change your regimen. Okay. So coming back to your operative thing, other than malignancy, are there any other indications of an MRM? Other than an invasive ductal or a lobular carcinoma, are there any other indications of the MRM?
If it is a recurrent phylloides tumor.
Okay, if it is a particularly recurrent malignant phylloides tumor, okay. Right. Now, what will you do with the axilla in such a case? Will you still address the axilla?
Ma'am, ideally, nodal metastasis is not seen in phylloides tumor.
Right.
But if it's recurrent, we sometimes.
So we don't address the axilla. What we do is not a modified radical mastectomy. We may end up with a simple mastectomy.
Yeah.
Also, extensive granulomatous mastitis, extensive granulomatous mastitis can be an indication for a simple mastectomy. But mind you, we will not use the word MRM because we are not going to address the axilla in such cases. Okay. So what anesthesia will you give? What will be the position and anesthesia of a patient of a standard MRM?
Anesthesia will be, ma'am, general anesthesia.
General
And
anesthesia with endotracheal intubation. That's going to be the full
Yes.
answer. Yes.
And position of the patient, ma'am, the patient should be lied at the edge of the table on the same side with the hand resting on the hand rest and arm flex at shoulder and elbow at 90 degree.
Arms
And
flexed at shoulder. Why will you flex the arm at the shoulder?
Extension.
Extension.
Abduct.
Exactly. So the arm, just put the arm on the arm board, and it has to be separately painted and draped. That is the point. So that the axilla is exposed.
Yes, ma'am.
Okay. Okay. Can you proceed with the incision planning, please? It was an upper outer quadrant, if you remember. I said it's an upper outer quadrant, T3 N1.
Yes. So then we have to give a elliptical. We can give a transverse elliptical incision, a steward transverse elliptical incision covering the nipple area complex from medially up to the just medial to sternum, medial border of sternum, lateral border of sternum, and laterally up to the anterior axillary fold. And
now,
then
I had said it is an upper outer quadrant lesion. Now, do you think a transverse incision will be adequate to cover this incision, or would you like to modify it slightly?
Then we can start towards angle towards axilla.
Exactly. So the ellipse will be slightly angulated towards the axilla. So you said it is lateral border of sternum. Please note it is not the midline of the sternum. It is lateral border of sternum to the anterior axillary line. Okay. What happens if your incision crosses the anterior axillary line? What is the problem that you might have to face?
Then, ma'am, later there will be contracture. And
okay, contracture could be one complication. What else?
And
see, if you think of it, if the patient requires post-operative radiotherapy, the whole scar has to be irradiated. So you have already done an MRM, meaning the axillary clearance has already been done. Over and above that, if your scar has to be irradiated beyond the anterior axillary line, there'll be some radiation going on to the axilla as well. So that is to be avoided. So your incision should stop at the anterior axillary line and not cross into the axilla. Okay. Yes. So fair enough. So you made an elliptical incision, including the nipple areola complex. How much skin should be included in that ellipse?
5 centimeter from the breast tissue.
Is it very rigid, that 5 centimeter? Is it a very rigid thing?
If the skin is not involved.
If it is, yeah, it is uninvolved skin, then would you still go for a 5 centimeter?
No, ma'am, then we can lessen it.
So yes, so the nipple areola with a paddle of skin, that is how it is described. They usually recommend around 2 to 3 centimeter on either side. But the point to be remembered is if it is healthy skin, you can still, there is something called a skin sparing mastectomy. You can still preserve the skin. But yes, if there are ulcerations, nodules, pudiorange, it is a good idea to excise that skin. Okay, what next? After the incision, what next?
Then we have to raise the skin flaps.
Okay.
Upper skin flaps will be raised till clavicle.
Okay.
And inferior skin flap will be raised till the upper border of rectus sheath.
The inframammary crease.
Yes,
okay. So at what level do you raise the flap as far as the thickness is concerned?
Subdermal.
Subdermal?
Dermal will be very thin. Not dermal.
What happens if it is a very thin, as sir said? What may happen? Very thin flap.
The flap may get necrosis. And
so there may be flap necrosis. So what is the optimal level at which you should raise the flap?
Ideally, we should see the veins. That's subdermal structure of veins.
So always you will not see the veins. I'm sure you've done MRM, so you will see. So at which level do we see? How do we judge?
The fats will be different, ma'am. The subcutaneous
Fats will be different. So how
breast,
will you distinguish? How will it be different?
the breast fat will be large globular
Okay,
fat.
so the subcutaneous fat globules are smaller and the breast globules are much larger.
larger.
So you go in the plane between the two. Okay, so that gives you a 5 to 7 millimeter thick flap. That is what we are looking at. But that differentiation has to be made. So you raise it up to the clavicle, as you said, and below up to the inframammary crease. Laterally and medially, how far do you go?
Laterally will go medially up to the 5 millimeter from the sternal border.
Okay.
And laterally up to the pectoralis major, lateral border of the pectoralis major muscle.
Lateral border of the pectoral. Okay, what do you do next? Which vessels might you encounter at this level?
The perforators of internal memory.
Exactly. So there may be perforators which you have to tackle. Otherwise, they tend to retract and they may bleed later. Okay. Okay. What next? You've raised the flap.
After
What next?
Then we have to separate the breast from the muscle, pectoralis major muscle.
Okay.
And then we have to cut.
Before you go further, when you are raising the flap, you are the surgeon, your assistant. What instruction do you give your assistant? How should he hold the flap when you are raising the
At
flap?
90 degree. At
90
90 degree to
degree.
the.
And what instrument should be used when he is lifting the flap?
I think skin hooks can be used.
Yes. And what not to use?
Alice.
Alice tissue forceps not. Why do we say this? What happens when you hold it with a clumsily with an Alice tissue forceps? What might happen?
Tissue ischemia leading to flap necrosis.
Exactly. So again, the edges might get necrosed. Now, if instead of holding it at 90 degrees, as you said, he holds it obliquely, that means towards himself, say 120 degree, what are the risks that are there if the flap is not held at 90 degree during dissection?
We may buttonhole into the skin. And
exactly. So you may buttonhole it. So that is why it is so important so that your assistant holds it fine. So you have lifted the flaps. You said you were going to lift the breast of the pec major. What is going to be the deep margin of resection?
Some people said to leave the clavipectoral fascia along with the breast tissue.
Clavipectoral fascia? Do you have the clavipectoral fascia in the breast?
Pectoralis fascia over the muscle.
Fascia covering pectoralis major. So do we remove it? Do we leave it behind?
There is a controversy. Some.
So what controversy are you aware of? Tell me.
Some says to take it and some.
Yeah, what is the reason? If the moment you have a controversy, there might be some points in favor and against. So what is the controversy?
It doesn't get in.
So what is the advantage of taking out the fascia covering pectoralis major? So the fascia is like a barrier. So when the tumor cells grow deep into the breast, so that is the first barrier that the tumor cells encounter before it penetrates into the pectoralis muscle. So they say that even though it has not invaded into pectoralis major, often tumor cells are seen on the fascia. So it is a good idea to take the fascia off. The other thing in favor of a fascia is that if you need to irradiate the chest wall subsequently, a fascia is another additional layer. So if you strip it off, the irradiation to the chest wall is more effective. These are the points in favor. So what you said, there is an argument. So what is the argument against it?
That not to take because
so some claim that the seroma formation, etc., is much higher because when you take off the fascia. So there is a debate, but most still prefer to take off the whole specimen of the breast along with the fascia covering pectoralis major, so that what lies behind is the bare pectoralis major muscle.
Yes.
Okay, what next?
Suppose
at some point you encounter that the mass, in spite of patient receiving NACT, is fixed to the pectoralis major at any point. How do you address that?
Then we have to take a margin of healthy pectoralis major muscle.
Exactly. So you have to take a part of pectoralis major, if necessary, shave off a part of pectoralis major so that you get a negative deep margin, at least grossly. Okay. What next?
Then we have to raise the breast till the lateral border of pectoralis major muscle.
Medial to lateral, lateral to medial. How
medial
do you
to lateral.
It is
medial
always
to lateral.
medial to lateral. What is the reason behind this medial to lateral raising of the mastectomy tissue?
Ma'am, laterally the axillary.
So that your dissection continues into the axilla. If you are doing it lateral to medial, they have to be two separate dissections. If you're doing medial to lateral, your dissection continues into the axilla. Okay. So how do you understand that you have reached the axilla? Or rather, how do you reach the axilla?
After we lift up the retract the pectoralis major muscle, we will see a fascia covering, and then if we incise it, then we enter.
What? Fascia covering what?
Axillary fascia.
So you are lifting it from medial to lateral. Once you're lifting it, you will arrive at the layer where you will understand that the pectoralis major has finished. There is no further pectoralis major.
Yes.
That is the lateral border of the breast. So you dissect it upwards. You dissect it upwards. And you would find a point where again the fat looks very different from the breast fat. So this is where you realize that you have reached the axilla. So you reach laterally up to the pec major, lateral border of pec major, and then you dissect it right upwards till you appreciate this difference. And you have a fascia there which is called that is the clavipectoral fascia, not at the breast. So what do you do? Once you've reached the clavipectoral fascia, what do you do?
We enter into the axilla.
You slit that and enter into the axilla. Okay. What is the first step once you enter into the axilla?
Then we have to identify that anterior border of latissimus dorsi muscle. You have to see.
So is that the first step? What is the first step? Yes, you will have to identify, but what is the first step that you do?
You have to identify axillary vein.
Exactly. You have to identify the axillary vein because that is which limit of your dissection?
Superior limit.
Superior limit. What do you do with the axillary vein?
We have to dissect below everything below it.
Below the axillary vein. What about the fascia covering the vein? Do you bear it? Do you not bear it?
You have to, sir, just incise along the vein transversely.
I didn't get you. Come again, please. I didn't hear you.
Ma'am, we have to incise the fascia over the vein and take the thing down.
So that is the point. You do not incise the fascia over the vein. You do not dissect the fascia covering the vein. What happens if you dissect the fascia covering the vein?
You may injure the vessels and
yes, injury is definitely an issue, but more importantly, there is extensive seroma again. So you will not bear the vein. Your vein is your superior margin of dissection, as you said, but you are going to identify the vein, not bear it, and start dissection below that downwards. Okay? So what are the structures that you are going to look for when you're dissecting? Axillary vein, yes. Anything else?
Then we have to look for the thoracodorsal pedicle.
Thoracodorsal, what are the components of the thoracodorsal pedicle?
Thoracodorsal artery, vein, and nerve to latissimus dorsi.
Nerve to latissimus dorsi. Okay. Now, where do you continue your dissection? Lateral to that or medial to that?
Medial to that.
Medial to that. Okay. Medially, what else do you preserve?
On the chest wall, there will be nerve to serratus anterior.
Nerve to serratus anterior, or also called the long thoracic nerve, right?
Long thoracic.
Long thoracic nerve. Okay. So that is to be preserved. Anything else?
And
anything else that you would like to preserve?
Intercostobrachial nerve.
Intercostobrachial nerves. How many intercostobrachial nerves do you encounter during your dissection?
Usually, ma'am, one.
No, a little more. Think about the spaces that you're dissecting, then you will understand. So it is usually the second to the sixth space, intercostal space, isn't it? That is the anatomical disposition of the breast. So you may encounter up to 3 to 4 intercostobrachial nerves. What do you do with them?
We can preserve it, ma'am.
So when will you preserve it? When will you not preserve it?
Ma'am, if there seems a large nodal burden and it's involved, when it's engaged in the nerve, then we have to remove it to maintain the oncology.
Okay, so the attempt will be to preserve it. But if you see that you are going to, your oncological clearance will be compromised in an attempt to save the nerve, in that case, you may have to sacrifice the nerve. Okay? Yes, Shaptashi?
Yes, ma'am. Yes,
Yeah.
ma'am.
Okay. Now, if you have to sacrifice the nerve, how do you cut the nerve?
With cold scissor.
Exactly. So you avoid using a diathermy. You just snip it off if you think that preserving it might leave behind nodal tissue, which is there. So what happens if you have to sacrifice the intercostobrachial nerve?
There may be hypoesthesia of medial side of arm.
Upper arm, medial part of upper arm may be present. Yes, medial part of the upper arm. So this is a post-operative discomfort that the patient might see. Now, if you go up and dissect beyond the first, we said it could be second to sixth intercostobrachial nerve. Now, what happens if you dissect the first intercostal nerve? Usually it does not come in your field, but if you're too adventurous and you go up, then what happens? Again, the seroma is very high because that area, if you dissect it. And secondly, this, if you do the first intercostobrachial nerve, the discomfort and hypoesthesia is very distressing for the patient. So normally we do not go up to the first intercostobrachial. It is the second to sixth. And if necessary only, then we will cut it. And when we cut it, we use a cold scissors, as you said. Okay, what else will you preserve? So you have observed the axillary vein. You have preserved the thoracodorsal pedicle and the nerve to the serratus anterior. Sometimes another vein is maybe present within that our dissection field. What can it be? Cephalic vein, exactly. So sometimes the cephalic vein and the axillary vein may run parallel and then join separately to form the subclavian vein, right? So you have to be cautious. You may get two parallel veins. Either way, you have to stay below the lower vein. That is to be there. You will get a number of other vessels, veins draining into the axillary vein. What do you do with them?
We may cut, ligate it and cut.
Yes, you can clip it and ligate it so that you get a good clearance. So what are you, these are the things that you preserve. What are the things that you are going to remove?
Enter the nodal part, nodes, fibrofatty tissue.
Right. And what will be the upper part was the lower border of your axillary vein. What will be the lower border of dissection?
Angular vein.
Angular vein, which is what? Which is the angular vein?
Branch from thoracodorsal.
So it is basically the continuation of the thoracodorsal vein, which just forms like a J and runs towards the latissimus dorsi. Why are we so intent on preserving the thoracodorsal? Why are we always saying that the thoracodorsal is to be preserved?
Sometimes it can be used for reconstruction.
Exactly. Which flap will be totally dependent on it?
LD flap, latissimus dorsalis.
So that is a very robust flap. There are other flaps as well. So if this is not routine, but if at a later time, the patient requires there's a recurrence and requires a reconstruction or anything, so an LD will be required. Even if in a primary setting, we are planning to do a primary reconstruction, the LD will be required. So you have to be very cautious because that is the extremely robust vessel supplying a robust flap. So that needs to be preserved. Okay, so you have preserved the two veins, that is the axillary and cephalic if it comes, and the two nerves, the thoracodorsal nerve and the nerve to serratus anterior. What
Yes.
happens after that? You have removed all this. What next? There is one more vessel that you have not talked about till now, which we preserve. A little higher up, think when we are just entering the axilla, you're placing your retractors. There's one more vessel which comes in the field.
Axillary artery.
Axillary artery is way above. If you reach the axillary artery, means you've gone way above your field. When you're placing your retractor, you ask your assistant to be a little cautious while putting the retractor when you're dissecting the axilla. So there are two more arteries. There are two more arteries. That will not come in the field, which will come between the pectoralis major and the minor. The medial and the lateral pectoral.
Yes.
Yes. Yeah. So those, medial and the lateral pectoral nerves will be there.
Yes.
So I'm sorry, I said artery, sorry, yeah. So that those you have to be cautious that you do not injure them. How are they anatomically positioned, the median and lateral?
Ma'am, medial pectoral nerve is laterally and the lateral pectoral nerve is medially.
So why this ambiguity in nomenclature?
Ma'am, because it's origin from the cords of plexus.
Yes, so the medial actually arises from the medial cord of the brachial plexus and the lateral from this. So this, when you are retracting, this position is usually between the upper part where there is a plane between the major and the minor. So when you are pulling your retractor, your assistant has to be cautious not to damage these nerves. Fair enough. So you finished your dissection, you've achieved good hemostasis. What next?
What is the extent of lymph node clearance? What is your plan?
Oh, yes. Okay. How much of the lymph node will you clear? You said I will remove all lymph nodes. Up to which level?
Level 1 and level 2 is must, ma'am.
Yes.
And level 3, ma'am.
Again debatable. Debatable.
Yes.
So what is level 1, level 2, level 3?
Ma'am, lateral to pectoralis minor is level 1.
Yes.
Behind the pectoralis minor is level 2 and above and medial is level 3, ma'am.
Okay. Now see, regarding, as you rightly said, regarding 1 and 2, there is no confusion at all. So what is the debate about level 3?
Ma'am, it said that if it is involved, then it already has poor prognosis. So removing will increase the morbidity.
So if it is involved, will you leave it behind then? If you see that after doing level 1 and 2 and you retract your pec minor and you feel deeper and you see there is level 3, will you leave it behind?
We have to give chemo, so it will.
No, you will still give chemo, but you will not do an incomplete clear.
Axillary dissection has become more and more conservative.
Yes.
While to address the axilla, but once it is involved, if you have a gross involvement of level 1 or level 2, there is a rationality for doing level 3 dissection.
Yes.
Otherwise, because now the people have gone more towards sentinel node biopsy. But in this patient, it was N1 node. So N1 node means either you are giving chemotherapy, and then there are a lot of other discussions on positive node also.
Okay. So the point is, see, if you have a positive level 3, then you are still justified in taking it off. But then what are the problems if you are doing a regular? There are some surgeons who still regularly do a level 3. So what is the problem with doing a level 3? Why are we now advocating that you do dissect less?
It will increase seroma and lymphedema.
Again, very high seroma formation. Sir, again, use the term lymph node sampling. What is that lymph node sampling that sir talked about?
Sentinel lymph node biopsy.
That is a different entity altogether. That is a different entity. We've not started that. Sir said that instead of taking out everything, we can do a lymph node sampling. What is that?
If clinically it was negative and we entered and feel some suspicious nodes, then we can send it for frozen section. If it comes to be positive, we can proceed for total axillary dissection.
Okay, so there are a lot of options now, and gradually, just like MRM has moved towards breast conservation and even minimalistic surgeries, even axilla. See, if there is a negative axilla, you do a sentinel lymph node, that's a different route altogether. If you find, as you said, intraoperatively, you might do a sampling, lower lymph node sampling. So that is where again you stay within level 1 and 2 only. You do not do an extensive dissection, but you are going to do a lower lymph node sampling. At yes, if they turn out to be positive, then there is a scope of irradiating the axilla. If you have done an extensive axillary dissection, you will again not irradiate the axilla because the chances of fibrosis and seroma and all that is very high.
Yes.
So if you do a sampling, you can follow it up with radiotherapy, right? We'll not touch upon sentinel lymph node now. Let us complete the rest of the discussion. If time permits, I will come back to sentinel lymph node discussion. Okay. So what's next? You have done the axillary. Then next what?
How can you avoid lymphedema? How can you avoid lymphedema following axillary dissection?
Yeah.
Now there is a concept that the arm lymphatics are different than breast lymphatics.
The breast lymphatics.
Reverse mapping is
reverse mapping. What is reverse mapping?
Sir, we give a dye in the hand and we see that.
So you are what you're trying to say is you are going to delineate the arm lymphatics by giving a dye. What dye commonly used?
Methylene blue.
Methylene blue, more it's better
now
something
you have more advanced.
ICG.
And then you are going to spare those lymphatics. So suppose at my hospital, I do not get ICG regularly. Is there any other way of preserving? You had already told that in your steps. You don't go lateral to the
thoracodorsal pedicle.
Exactly. So that is the reason, so that we avoid the arm lymphatics. Unless you have gross nodes there. Then you're not going to leave it behind. If there are no nodes like N1 and it is all medial to the thoracodorsal pedicle, then yes, you can avoid the lateral dissection. This is going to preserve. ICG, very good option. You can just, where do you inject the ICG when you are looking for the reverse mapping?
In the
upper arm.
Anatomical.
Yes, medial aspect of the upper arm. Right? Okay. So that is where you inject it and it is going to flow upwards and you will see that those lymphatics are separate from the breast lymphatics. So those are the lymphatics which you are going to avoid dissecting. And they are usually lateral to the thoracodorsal. So principle wise, you will not go lateral to the thoracodorsal unless there are positive lymph nodes there.
Yes.
Okay. Okay. So what next? What do you do next?
After removing the fatty tissue, we can, the nodal axillary dissection, we can then secure the hemostasis and put drain. And
how many drains do you put? What sort of drains do you put? 2. Where do you place them?
One under the flaps and one in axilla.
Okay. Again, lot of discussion on that. Some you choose to use 1 only, 2 only. No benefit of one over the other. It is a surgeon's choice. It is a negative suction drain. How much suction do you use?
For the first day, we give complete suction. And
yes.
From next day onwards, we can put in half suction.
What is the logic behind this?
If we give full suction, then there may be a damage and the seroma will be collection.
So not damage, it is seroma. Again, you are stimulating the nerve ending so much that there is more seroma formation. So yes, you're right. First day, you tend to give full suction so that not only serous fluid, any blood, anything collecting there is sucked out. And subsequently, we make it into half suction. Okay. When you close the flap, what are the things that you have to keep in mind? Now you're bringing the 2 flaps down and closing it.
There should be no tension in the flap.
Okay. Okay. What else?
The edges must be bleeding so that.
Edges must be obviously not ischemic. Again, the scar line should not go into the axilla or should not go into the shoulder. So that is very important right from the beginning when you are planning your incision. Sometimes we see very ugly scars going into the shoulder and these invariably lead to contracture and poor quality of life later on. So next morning you put it, is there any role of when we started doing our training, we used to put a ball of cotton in the axilla and pressure dressing and all that. Is there any role of that?
It will decrease the seroma formation.
No, it doesn't actually. So that is the point. You have to achieve good hemostasis. So you do not achieve good hemostasis and you put a pressure later on, that really doesn't work. So it is better avoided now. So from next morning, what will be your advice to the patient?
From next day, little exercises.
What sort of exercise are you talking about?
Slowly lifting the hand above.
Shoulder exercise.
Shoulder exercise. Yes.
Okay. Anything else? You've done a formal
combing.
MRI.
Combing.
Combing. So that is also a shoulder exercise, isn't it?
Yeah.
Anything else? Any other type of exercise which will, improve the lymphatic drainage of the limb?
We can ball.
Exactly. So that from next morning, you encourage the patient to, squeeze her hand, maybe use a soft ball. That is going to improve her venous as well as the lymphatic drainage. The shoulder exercises are not advocated the next morning. Reason being, immediately post-op, if you start shoulder exercise, that has again been shown to increase seroma formation. So by 24 to 48 hours, then you start your shoulder exercises. What happens if you delay the shoulder exercises? Initially, patient may not be very compliant because of pain and other issues. What happens?
Frozen shoulder.
Exactly. So you might have stiffness in the shoulders. So right next morning, you start your, lymphatic drainage exercises, and 24 to 48 hours later, you start your shoulder exercises. Okay. So now you have, let's say day 3, you have removed the dressing, you've done a wound, wanted to do a wound check. What complications can you encounter following an MRM?
First, there may be a hematoma or
seroma.
Okay. Seroma.
Take it one at a time. When you said hematoma, where?
Below the flap.
Usually, seroma does not happen in the next morning.
Yeah.
Initially, it is a bleed and then it starts forming seroma.
So you have to keep looking at your suction, what is coming, right?
Yes.
Okay. Now, there are some activities which as a resident you must have done, that you see that there is a clot in the suction. So you aspirate, or it is called the declotting of the drain. If you do not do that, then it is going to collect inside. So when there is a collection inside, what is the problem? What can happen?
Discomfort for the patient.
Definitely, that is one aspect. What happens to the flap if there is a collection inside?
Flap may get stretched out and necrose.
Lifted, yeah, that's the point. So the flap is supposed to sit on the chest wall, isn't it? If there is a collection, the flap will get lifted. So then that flap might get compromised. So you have to ensure that your suction drain is well cleared and the drainage is adequate. Okay, so you have to declot the drain as required. So one thing is that the flap is lifted up. So that can be one complication which may lead to a subsequent flap compromise. What else can happen? What else can happen? What other complication can you encounter?
Any color change in the flap?
It may turn blackish.
Okay. So usually what you must have seen is it's the edges which are a little blackened.
Yes.
So just let us assume that just the edges are blackened. What will you do?
If it is very little, ma'am, we can just continue dressing and
immediately do not remove sutures. Just wait and watch. Wait and watch whether it is progressing or not. Okay. Let us say it is a little worse, that there is an area of say 2 to 3 centimeter, which is, dusky. What do you do?
If it is not showing any improvement, then we might have to excise it.
So again, the first attempt, you're not going to, just cut it. Sometimes it is just a very superficial layer, which is dusky, which might, fall off. But the deeper layer may be good. So it's not, don't get aggressive and debride the ischemic part right away. Let us say that it is not improving. You're continuing your dressing and the blackness is getting more. Now, what do you do then?
Then we have to excise the...
Then you have to debride. What is the problem when you have to debride? Suppose you do have to debride, there's a big area which is totally devascularized. What is the problem?
Closing will be difficult, and again,
Closing will be difficult. Understood. What else? Okay, let us say that you say you cannot close it, so you continue to dress it, and it heals by secondary intention. But what will be the net problem? What will be delayed?
Radiotherapy or chemotherapy?
So the adjuvant therapy is going to delay. If the adjuvant therapy is delayed, there is a compromise in the outcome of the patient. Now the point is, we said that you immediately do not debride. You wait for a while, see whether it is improving, not improving, ischemia is increasing. At the same time, we are saying you cannot delay it. So what is an optimum time by which your adjuvant therapy should definitely start?
4 weeks ideally.
8 weeks. 8 weeks, around 6 to 8 weeks. Okay, so whatever you do, your wound management, you have to keep at the back of my mind that I must start the patient on her adjuvant therapy by 6 to 8 weeks. So that is what is going to trigger you that, you know, I should not delay the debridement anymore. I should expedite my wound dressing so that it heals and I can start my adjuvant therapy by 6 to 8 weeks. So that was about flap necrosis. That was one aspect of complications. What could be the second common complication? Very common complication. Seroma formation. So how do you know that there is a seroma?
If the continuous drain output is more.
So if the drain is in C2 and it is draining out, fair enough, then the problem is sorted. Usually what happens is it was not coming, then you have taken out the drain and then you see that the patient comes back with a boggy swelling.
Yeah.
Yes.
So that is how the patient presents. So what do? Patient has come back to your outdoor after 7 days and there is a boggy swelling. Patient feels it is very tender. I cannot put my hand. It's a little reddish. What do?
We have to aspirate in sterile condition.
Take full precaution, sterile precaution and aspirate it. Fair enough. Okay. So you send the patient home, ask her to come back the following week. Next week she comes back. There is a recurrence of the swelling.
Again, we have to aspirate.
You have to again. So how long do you go on?
As long it...
Proti shaptahe asho ar ekটু করে আমি টেনে দিই, that cannot be, right? So how long do you go on?
2-3 weeks.
Exactly. You can take 2-3 sittings of aspiration. If it is settling down by them, fair enough. If it is not settling, then what do you do? You might have to reinsert a drain, preferably under US guidance, and keep the drain. Because if you let the seroma collect, ultimately it is secondarily going to lead to, number one, it can get infected. Number two, again, a flap compromise may occur. So there have been reports of patient requiring a drain even as much as 1 or 2 months. So you might have to put a drain under US guidance. You're not saying that you open up the chest wall again, under US guidance, and leave so that the seroma does not collect inside. You have to remember that somebody said that why aspirate it in the first place? Dr. Rishi Ranjan wanted to know. Shaptoshi, can you answer it? She said, why aspirate it? Leave it behind. That was his question. Shaptoshi, would you like to address your friend's query? What happens if you leave it behind?
Patient having discomfort, so CKM.
Number one, discomfort. Number two.
It may increase more and more flap or compromise.
So
and
the flap will get raised. So there will be a flap compromise. Number three.
Come through wound and it may cause wound gapping.
It will give wound gap. It will give wound gap. That's a flap compromise again. Number three. Can it get infected? Can it get infected? Yes. So the seroma might become an infected seroma. So that is why you said, you know, take full sterile precautions. We do not want to introduce secondary infection into it. So it might get infected, turn into an abscess. So ultimately you will have to drain it. So it is always better to prevent than to cure. So you have to, if you see a seroma, unless it's a very small seroma, then you can give an attempt of conservative management. But otherwise, it is always better to aspirated under full sterile precautions. Rishi, I hope your query is addressed. So you said that, yes, you might have to leave a drain if necessary, if you see that the patient's seroma is not responding. But the first step to a seroma formation is as much as possible a prevention, which should be how you're dissecting the axilla, whether you are bearing the vein, axillary vein or not, whether you're going too high up, whether you're going too laterally. All these are factors which will deal to how much of seroma is forming. Any other complications? So flap necrosis, seroma. Number 3.
Any injury to vessels and nerves.
Which vessel? Be specific.
Axillary vein mainly.
Axillary vein injury is a major intraoperative catastrophe.
Yes.
Okay, so that has to be addressed intraoperatively. I'm talking about subsequently.
So if I have a long thoracic nerve injury, what
happens?
disability patient may have?
Winging of scapula will be.
You can have winging of scapula. Okay, what else? Intercostobrachial, you have already said you can have a patch of hypoesthesia in the upper arm, and it can be very distressing if you go high up into the first intercostobrachial. What else? Something very common for which, axillary dissection is gradually getting de-escalated now.
Swelling in the?
Yes. Yes, there could be lymphedema. That is a very distressing complication for the patient. So there again, the key thing should be prevention as much as possible. So your meticulous dissection, use of ICG if possible, avoid the arm lymphatics, and initiate early arm exercise so that the venous drainages, venous and lymphatic drainage is proper. What if a lymphedema has occurred? What do?
We will to advise patient to keep the limb elevated and.
Yes. So the exercise and elevation, all that is the initial treatment. Let us say it is progressing and patient is extremely uncomfortable. Are there any surgical maneuvers or surgical things that we do, experts do, when I may not be able to do it?
During primary surgery. Now this is being done during primary surgery even.
Lymphovascular anastomosis.
Lymphovascular anastomosis. What is the basic principle?
The lymphatic channels anastomosis with the vascular. So
which lymphatic channels?
Arm lymphatics.
Arm lymphatics. So the arm lymphatics are being dunked inside a vein so that, they drain inside the venous system and the lymphedema does not occur. So yes, as Sir said, sometimes it is done primarily also. Later also it can be done, but mind you, once you have a grade 3, 4 lymphedema, then it is not very effective. It has to be picked up early. Again, the picking up is by an ICG imaging, picked up early and then done, especially done by experts doing it, maybe plastic surgeons, and some of the breast surgeons are also now doing it. So that is another very common complications. So is there any way we can fix the breast flap, which has been shown to reduce seroma formation? Normally we just bring the flap together, put a subcutaneous layer and then close the skin. Is there some people practice some modifications of closing the flap, which they say that reduces seroma formation? Are you aware of it?
Quilting, they do quilting.
Exactly. So there is something called quilting. Basically, what is the principle? Why does it reduce the seroma formation?
So the dead space is obliterated.
The dead space is obliterated. So right from day 1, you are fixing the flap to the chest wall. So that the dead space is obliterated, any serous fluid which is forming gets absorbed by the surrounding tissue, does not collect under the flap. Yes, so quilting is a thing, though not very popular, but still there are surgeons who prefer to do it with the aim of reducing the seroma. Fair enough. Now that when will you remove the drain? You had put a negative suction drain. When will you remove the drain?
When the drain output is less than 40 for 2 consecutive days.
Right. So this is again a debatable thing. The point is, yes, as you correctly said, you make it a half suction drain from the second day and you follow the drain output. When you see it is decreasing and it is less than, some say 30, some say 20. There is no correct fixed answer to it, but you remove it once the purpose of the drain, that is to drain, has been satisfied. So 10 days later, the patient comes to your OPD with the histopathology report. Now, in the histopathology report, what are the 7 or 8 things that you're going to look for?
First, the biopsy, whether it is invasive ductal carcinoma.
So the histopathology.
Yes.
So the histopathology.
Size of tumor.
Okay.
Size of tumor. Nodal disease. How much?
Okay. What about the nodal disease?
These are PT. You mean PT now?
Yeah. So you're talking about PT, pathological T staging, right?
Yes, ma'am. And pathological nodal staging also.
Nodal staging. What about it? Just nodal staging means what?
Ma'am, how many are positive and how many samples?
Nodes? Okay. How many nodes dissected? How many positive? What
positive,
else?
Yes.
What else about nodes?
Extranodal extension is present or not?
Exactly. Extranodal extension, breach of nodal capsule, whether it is present or not. Okay. What next?
And then if ERPR status, if not done.
Okay. ERPR, Hartinu, Ki67 status. What else?
Lymphovascular invasion.
Yes. Lymphovascular invasion present or not. One more thing. Perineural invasion present or not. Okay. Something very important, right, when we were doing the gross tumor thing you have not mentioned yet. The margins.
Rejection margin.
It is not common that in MRM you may not find, but yes, it is still possible in extensive diseases, the margins. So which margins are you looking at?
Mainly, ma'am, around the tumor.
All. Okay.
All.
Lateral, medial, posterior, inferior, and more importantly, the deep margin. Particularly in MRM, we would like to see the deep margin, because remember I had said that at some point it was fixed to the pec major and we had shaved a bit of pec major. So the deep margin is something that we have to be careful about. Okay. So following this histopathology, which are the findings in your histopath report which will tell you that, okay, if the patient has completed her NACT, fair enough. If the patient has received only partially her NACT, the rest of the NACT has to be completed. But which are the findings which will tell you that post-mastectomy radiotherapy may be required? Do all patients of mastectomy require radiotherapy?
Ma'am, if the nodal disease is present, N2 disease.
Okay, so all nodal disease?
4+.
4+. 4+, extranodal extension, nodal breach, capsular breach. These are the patients who will need radiotherapy. So which parts are irradiated? This is different from the irradiation of the breast, in breast conservation, mind you. Which parts will be irradiated?
The whole breast with boost in the tumor bed.
No, but this is a mastectomy. How can you have you don't need the boost?
We have not addressed the internal memory node. We have not addressed the supraclavicular node. So if you are irradiating, none, these areas are also to be included.
So it is called a PMRT, post-mastectomy. Don't say whole breast is irradiated. You remove the whole breast. So you cannot irradiate it anymore. So it's called PMRT, post-mastectomy radiotherapy. So it is a chest wall irradiation, including supra and infraclavicular and internal memory. And usually the level 1 of the axilla comes within the field. This is called post-mastectomy. When you irradiate after BCS, that is when you are going to say WBRT, whole breast radiotherapy with a boost to the cavity where the tumor was. Okay, so the two are distinctly different. I will not go into the nitty-gritties of the doses and all that. That is usually decided by your radiotherapist, but this is going to be a PMRT. PMRT including supra, infraclavicular, internal memory, and the level 1 comes into the field of the. Now, sometimes you may see that your anesthetist gives some block either during your primary anesthesia or sometimes at the end of surgery to make the patient very comfortable. So any idea what these blocks are?
Erector spiny block can be given.
Erectus spiny block can be
spiny
given.
block.
For erectus spiny, you have to turn the patient in the same position. Sometimes when we are operating,
Pectoral block.
pectoral block, pectoral 1 and 2 block. What is blocked by these? Which nerves are blocked by this?
Intercostal.
Intercostal. Anything else?
Pectoral nerves.
See, as the name suggests, it has to be pectoral, right?
Yes.
So there are two, they injected at 2 points. So between major and minor, when they block the area between the major and minor, it is going to block the medial and lateral pectoral nerves. Remember, we had said that we have to avoid damaging it.
Yes.
Right?
Yes.
And the second is at the level of the intercostobrachial nerves, usually second, third, and fourth. So they do 2 blocks. They might do it from outside, or they may give the injection to the surgeon, and it is totally under your vision. So you can very well block it, and this ensures that the patient is comfortable, can initiate, their pain is less, and can also initiate her post-operative physiotherapy very promptly. So PEC 1 and 2 blocks are important. Any other blocks which are, supplements? You said one was erectus spiny. Anything else? Sometimes very sick patients, they may attempt, but not very common. The surgery is only attempted under blocks. Just think of all the nerves present there. You will get some idea.
Brachial plexus block.
Brachial plexus, no, as a whole, you don't block. Brachial plexus is mainly, it will go in, the whole arm will get. So serratus anterior, you said the serratus anterior is there. You can have a thoracic paravertebral block. Thoracic paravertebral and erectus spiny, the patient has to be turned. And you can also have parasternal blocks. So if you're doing it totally under blocks, you may need a combination of these and preferably under US guidance. But otherwise, just for post-operative analgesia and comfort, a PEC 1 and 2 block is usually advocated. Okay. Sir, do we have time for sentinel lymph node or anything more, sir, you want to add?
Sentinel node will discuss separately in early breast cancer.
Sir, anything else you want discussed
No,
for a month?
For operative, we have done enough. Well discussed.
Well, thank you, Shaptoshi. I think you answered quite promptly. If anybody else has any questions which they want to get clarified, we have only 2 minutes to go. You can come up with your queries.
Shaptoshi, you are appearing in the exam in June, na?
Yes, ma'am. Yes, sir. Yes, sir.
Yeah. Good. Well answered.
Okay. Thank you, sir.
Okay, sir. I don't think there are any other queries.
Yeah.
In that case, we will terminate the session. Thank you, Shaptoshi. Thank you, sir.
Thank you, ma'am.
Thank you, others, for participating. I'll log off now.
Thank you.